So I hope that you all enjoyed lunch. Thank you for joining us after lunchtime, and we will try to get very excited so that you are not in a lunch coma. Oh, thank you. Appreciate that. So we're going to restart our symposium with a panel about the most important component of the learning health system, the people. Every year that we've hosted this symposium, we have had a panel dedicated to the theme of equity, and this year is no different. And we will have two speakers presenting their findings on individual patient and participant perspectives, and then two speakers focusing on community perspectives and ways to ensure that institutions are responsive to the communities which they serve. Each presentation will be 20 minutes, and we will hold all questions for our discussion at the end of the presentations. So I'm going to introduce all of our esteemed panelists and then invite Andrew to begin. So our first speaker for this panel is Dr. Andrew Schumann, and he is an assistant professor in the Department of, I've got this, don't tell me, otolaryngology. Oh God, say it. Yeah? All right. Head and neck surgery at the University of Michigan Medical School. He is also the chief of the ENT section of the surgery service at the VA Ann Arbor Health System. At UM, he serves as the co-chief of the Clinical Ethics Service in the Center for Bioethics and Social Sciences in Medicine and the chair of the Adult Ethics Committee. Dr. Schumann's research focuses on cancer treatment decision-making and precision oncology. And today he'll be talking about patient and provider perspectives on precision head and neck oncology. After Dr. Schumann, we have TJ Kasper-Bauer. He will be talking about incorporating biobank consent into the clinic, challenges for improving patient understanding. TJ is a postdoctoral fellow at the Indiana University Center for Bioethics, where he conducts research on privacy and protection of health data, informed consent, and ethical issues in learning health systems. He is the author of Subhuman: The Moral Psychology of Human Attitudes to Animals. He is a former postdoc in bioethics at the University of Copenhagen, where he was involved in a collaboration between researchers and clinicians, BrainStem, studying the use of stem cells for treating neurodegenerative diseases such as Alzheimer's, and investigating privacy issues in biobanking and how privacy risks should be communicated to patients. Next will be a team of Karen Calhoun and David Cordova. Karen Calhoun is a community-engaged research program officer with the Michigan Institute for Clinical and Health Research at the University of Michigan. She provides leadership locally and nationally, incorporating diverse interpretations of lived experiences and collaboration to improve community and population health. As a community scientist and practitioner, she relies on multidisciplinary preparation and relationships to strategically lead change and solve problems in the areas of community health, equity, poverty, and community economic development. And last, certainly not least, is Dr. Cordova. And Dr. Cordova is an associate professor at the University of Michigan School of Social Work. His research focuses on preventing and reducing substance use and sexual risk behaviors among youth. Currently, he is conducting a randomized controlled trial to examine the impact of a technology-based substance use and HIV preventive intervention on youth risk behaviors. Thank you to all of our speakers. I'm really looking forward to this, particularly as we delve into these issues of equity, which were touched on the last panel, and I'm hoping that the patient focus of this panel will really move us forward in thinking about the ways in which we actually treat, care, manage the people who are at the center of a learning health system. So Dr. Schumann, will you please start us off?
Thanks so much for the opportunity to present to the organizers of this great conference. I first just wanted to acknowledge the many people who have been a part of the work that I'm doing, as well as some very generous funders who have supported many of the research that I'll be presenting over the next few minutes. But I'm going to start with a case. So this is my patient. I am first and foremost a doctor who also has the privilege of doing research and doing work in ethics, but I'm really a doctor. And this is the story of Susie. Susie is a woman who's in her 40s. She's an advertising executive who comes into my clinic complaining of a lump in her mouth or a lump in her throat. This is really common. Most of the time, it's nothing to be too worried about, but unfortunately for Susie, it is. She has a very rare, very slow-growing tumor in the back of her tongue. And the advantage of having a slow-growing tumor is that it doesn't spread quickly, but it also means it's not going to be particularly responsive to non-surgical management. So for this rare salivary tumor, surgery is really the only option for curative intent. The problem with the location of this tumor is that surgery for Susie would involve taking out her tongue, which is something I do and something that people recover from, but with a significant impact upon quality of life, eating, drinking, communicating, speaking, and so on. And for a 40-something-year-old advertising executive who otherwise feels great, that is a tough thing to hear. So Susie and I maintain a relationship. We see each other frequently, and she essentially says, let's wait and see. Let's give this some time and see what happens. I'm not ready to sign up for this operation. I maintained a relationship with her for years. I would see her every few months. The tumor would gradually get bigger. Her symptoms may or may not evolve over time, but not enough that she's willing to do something about it. Eventually, it spreads to lymph nodes in her neck. They grow quite large. Her tongue tumor grows quite large. And eventually, she gets to the point where she says, okay, now it's time, years after being diagnosed. This entire time, I've been very worried that if we wait too long, there won't be a surgical option. And indeed, at the point where she finally decides she wants to do something about it, the tumor has spread to the point where it cannot be surgically removed and cannot be cured. At that time, she's grasping at straws and says, gosh, can't we do anything else? So we enroll her in a precision oncology protocol where we sequence her tumor and look for anything targetable. The good news is we find the driving mutation, and it's actually quite clear what's causing her tumor. The bad news is it's not targetable. Susie and I have become friends at this point. I've seen her for many, many years at this point. And she essentially says, gosh, you know, this time I thought this was going to be the answer. And I'm really disappointed that it's not. So every case is different, and bad cases make bad ethics, so to speak. So we're not going to be framing an entire discussion around her case. But I do think it's important to have a patient in mind when we're talking about data, because at the root of it, Susie is really who we're talking about when it comes to precision oncology and the vulnerability thereof. So part of what we're discussing today, and I'm not going to reiterate what's been discussed at this conference for the last 3 years, other than to say that we tend to conflate clinical care and clinical research in ways that are not necessarily helpful. So generally speaking, patient-centered care is based upon the primacy of the beneficence of that individual patient. We are trying to help a patient in front of us, rather than trying to help a population of future patients. As a result, we create an inherent vulnerability when these individual patients become research subjects. There's also the problem with the therapeutic misconception, which is very well described, and to oversimplify it, the fact that patients who become subjects do not necessarily realize that research is meant for generalizable knowledge rather than for their own benefit. In precision oncology, things are a little bit different, not dramatically different, but somewhat different. And the reason for that is because it is very difficult for patients to conceptualize what research means for them, especially when we tell them on billboards and in paperwork that we are going to target or tailor or personalize their individual treatment based upon their genetics or other variables. When people hear that, it's quite tantalizing, and they assume that means they're going to benefit. Unfortunately, the state of the science in precision oncology is such that we're actually not benefiting nearly as many patients as we think we are or will hopefully do in the future. I've made an argument which I would posit states that the informed consent process for precision oncology research is more nuanced and more difficult than for patients who are becoming subjects in other fields. This does not necessarily mean that cancer patients are different than everybody else, or that my patients are different than everyone else. But I will say, as a surgical oncologist who deals with these folks on a daily basis, as well as someone who's fairly well versed in the research on this area, there is something fundamentally different when you're sitting across from someone who is facing losing their tongue and having a conversation about enrollment in precision oncology research or sequencing their genes. So with that said, we've done a study, and I'm excited to present some of these data to you today, in which we really tried to understand not just Susie's perspective, but that of her doctors as well. So what is driving the motivation for patients and their providers to sign them up for precision oncology protocols? How can we evaluate the stakeholders' perspective on what that informed consent process looks like? And how is this different, and what can we learn moving forward? So very briefly, this is a nested ethical analysis and study within my OtoSeq, which is a precision oncology protocol specific for head and neck cancer patients. I'm not going to delve into the science details thereof, other than to say this is upfront targeted genomic sequencing of patients with head and neck cancer, some of whom have lower stage or easily curable cancers, others whom have much more advanced stage recurrent refractory cancer. So this is a panoply of different patients with different prognoses. They're sequenced, and that data may or may not impact their clinical care. So what we did is a multi-method embedded protocol in which we did surveys, paired surveys of patients and their providers for every patient prospectively who was a part of this for about a year or so, so that was a little over 100, and then purposefully sampled semi-structured interviews, again, of patients and their providers right after their enrollment. And right, I think I covered that. So what is our goal? Our goal is really to understand how people made decisions about being enrolled in this, and what are their perspectives about what they think they're going to get out of it. And of course, comparing what the clinicians who signed them up for this, as well as the patients, had to say about it. This just goes through some of the semi-structured qualitative analysis. And here are some of the results. So the first thing we found, which was very striking, and quite frankly, pretty self-evident from the data, the extant data, is that everybody was pretty supportive of this. And again, we're all at the University of Michigan. We're all drinking the same Kool-Aid, right? So we all believe in research. We all think that there's value here. There's a reason these people came to see us. And surprise, surprise, they are all for research. So you can see some of these quotes. You can't make it up, but literally a patient said, "Just call me guinea pig, do whatever you want to me." And the general sense here is that there is a promise, an understated but very evident promise, that being a part of genomic research is the future of medicine. This is going to cure cancer, and we can't wait to be a part of it. Another aspect of this relates to reliance and trust. And here I'm bringing some of the survey data in that many patients said, or really all of the patients, with few exceptions, said that they engaged in a discussion with their providers about being a part of this research. That everybody thought that their involvement in this research was at least driven in part by their clinicians. But what's really interesting is there was a fair amount of discord about how much of a role those providers actually had. So the clinicians, all of whom are oncologists, so these are surgical oncologists, medical oncologists, and radiation oncologists, all of whom take care of patients with head and neck cancer. The vast majority, if not all of them, said we were the most important part of making sure that this patient understood what they were getting into and motivated them to sign up for the research. But when you ask the patients, that wasn't necessarily the case. These patients essentially said that they decided based upon discussions with their partners, based upon their own opinion and so on, and less driven by their clinicians' input in that actual decision. Another interesting component of this is that clinicians raised the concern that patients are signing up for anything. They're willing to be guinea pigs, so to speak, and that they're not necessarily listening. And this is an interesting paired set of quotes. So these are from clinician 7 and patient 7. So this is the same dyad in which a clinician says, well, gosh, these patients are willing to say yes to everything. It's not really informed consent. Maybe it's assent with a signature, but it's not consent. And that patient, at least there was concordance here, said, yeah, that's exactly right. It was a no-brainer. I barely even read anything, and I just signed up. Another part of the reliance and trust issue here is that patients didn't necessarily sign up because they trusted their clinician, but they trusted the Block M. They were coming to the University of Michigan. They're coming to the leaders and the best, and they wanted the best care possible, and that trust started when they walked in the door, not when they met someone or when they looked at Yelp reviews or anything else, and certainly not when they got an informed consent document to review and sign. But they had trust before they stepped in the building. And again, that striking component, that half of our patients said that they made their decision to participate with little input from their cancer doctor, which is the exact opposite of what the cancer doctor's perspective would be. And again, I think I spoke about that 91% discordance. So that's one of the most striking areas of discordance in these surveys. Another aspect that's come up is the therapeutic misconception. And we, in research ethics and clinical ethics, talk about this frequently. Weinfurt's work is really seminal here. The concept that, to some degree, participation in clinical research is based more upon optimism than altruism. That these people are signing up because they think they're going to get a benefit, not necessarily because they're trying to help the community. And what was striking was that this was only a concern of clinicians. This was not a concern of the patients who were part of this specific part of the research. With that said, there's a couple of quotes here from the clinicians. When you tell someone it's voluntary, is it truly voluntary? I think they were just happy to be around to help. There's an issue here with dual role, and Professor Morain's work is particularly apropos here, which was, there was a beautiful panel at ASBH talking about this. The concept that when a clinician is also the researcher who's consenting a patient, there is an obvious tension. And should that clinician really be the one who's signing someone up for a trial? You can make an argument that perhaps the surgeon who's going to be operating isn't necessarily the person to get objective perspectives on whether or not you want to participate in his or her research. With that said, in this setup, the clinicians were not the consenting individual. There was a separate clinical research coordinator who went through the informed consent process. However, the clinician obviously was part of the discussion that led them to enroll. So in summary of this aspect of the results, patients and clinicians were quite enthusiastic about research. They described on a reliance of information and trust in their cancer doctor, but not necessarily to the same degree that the cancer doctor thought they were influencing their decision to enroll. And finally, that we need to think about therapeutic misconception a little differently because it's really more of a concern, at least in our data, from the clinicians rather than the patients and subjects. So with the last few minutes, I'm going to talk about commercialization. So this is another arm. What we also, as part of our blanket broad consent, University of Michigan, for patients who consent to participate in research, have their biospecimens that can be used for additional secondary research in a de-identified matter. And this is all part of the consent process, which also makes it clear that these data and specimens can be commercialized. So what we wanted to do was ask patients and their providers in these same interviews what they thought about that commercialization. And that's kind of where we were coming from. So what's fascinating was this was one of the strongest areas of concordance between clinicians and patients in that no one understood what they had actually signed up for. So significantly, a major significant theme was the fact that patients and clinicians did not realize that they had actually consented to commercialization of their specimens. So a quote from a patient, "I hope you don't commercialize because I don't think you said you would, or did you? I don't remember." And then followed up, "Well, if you do, I'm going to get my lawyer because you promised that none of my information would be given to anyone." And then a clinician, again, who's part of this study, said, gosh, he wouldn't be excited about that possibility. Maybe there should be some language in the informed consent form. And of course, there's multiple paragraphs. Another question that we asked was, how do you want these profits utilized? So since you've already agreed to commercialization, whether or not you remember doing so, how do you want us to use that money? What should we do with that money? And one patient participant said, well, I don't want you to put it in your pocket, and that just doesn't sit well. How are you going to make money off of me? And I don't want a pharmaceutical company to do that because I'm not their business, and that's one of the best quotes. My research is their business, but I'm not their business. But with that said, the majority actually said, well, if you're going to make money, can you invest it at least in something I care about? Something like, oh, I don't know, head and neck cancer. So the reinvestment was a key component here. And there was a fairly significant, not universal, but significant theme that patient participants, as well as their clinicians, wanted the money to be reinvested in the research enterprise for which they were participating. With that said, the patients were actually much more comfortable to have their data commercialized and have that reinvested than were the clinicians. So the clinicians were actually much more protective and leery of that commercialization than were the patient subjects themselves. So there's three major themes that come out of the commercialization part here. So people don't necessarily understand whether or not they're clinician or patient. Patients were more comfortable than their clinicians with that commercialization. And there was a strong preference not just to reinvest in the enterprise, but in the specific research enterprise for which they are signing up. So what did we learn from this? That patients and providers need to be better educated. And you might make an argument here that this was actually, in some case, a best-case scenario. Our clinical research, so patients received their informed consent forms well in advance. They had separate conversations with their clinicians as well as with their clinical research coordinator. And the clinical research coordinator who was consenting them knew that she would be interviewing them, asking about how much they understood from the informed consent process afterwards. So this is a clinical research coordinator who is going to be as invested in doing a good job as anyone else for a Hawthorne effect, if for nothing else. And what we found was even with that level in this experience, people didn't really get what they were signing up for. So there's a couple ways of thinking about this. Number one is we need to build a better mousetrap, and we need to do a better job of consenting people, which is self-evident. But I would also argue that perhaps what we need to do is accept that patients and providers, patients specifically, may never really get or grasp the magnitude of what they're signing up for. Because again, remember Susie. Susie is thinking about dying of cancer and losing her tongue. And quite frankly, what happens to her data and whether or not a company may or may not make some money off of it down the road may be way down on the list of her priorities. So while I'm not at all saying it's not important for us to consider that and to enable people to make the right choices for themselves, I would posit that perhaps we're focusing on something that patients and subjects aren't quite as worried about as people in this room might be. So these data, if nothing else, are a step forward to better understanding that nuanced perspective of the patient and the provider. And I welcome comments and questions related to this. I think I'm close on time. So from where we go from here, better informed consent processes would be great, but we've been saying that for 30 years and we haven't done much work in actually achieving it. Not to say we shouldn't do better, but perhaps that's not the only answer here. We can and should think about how to make research sustainable, which does involve reinvestment of profit and working with industry. And we need to do so in a way that is regulatory, compliant with regulation, obviously, but also in a way that's sensitive to the fact that not every patient is going to understand what they're actually a part of. And maybe that's okay. Thank you.
There we go. Yeah. Sorry about that. So you're going to be hearing some similar themes in my talk about consent. So I'm presenting some research I've been doing in the last year with the Indiana Biobank on consent and consent understanding. Its relevance to this conference, the IU health system, which is connected to the Indiana University School of Medicine, is, they have a precision health program. They're trying to be a learning health system. And a big part of that in the last year is making a biobank process, a biobank collection process that's integrated with patient care. So the ultimate goal is we're going to start collecting biospecimens from everyone as soon as they enter into an IU health clinic. Over time, there will be some return of results potentially. The long-term outcome is related to the learning health systems and precision health. The issue is sort of relevant to what Andrew was just talking about. When we approach people in the clinic, they're not thinking about the biobank. They're thinking about their illnesses, other things, and we approach them and say, hey, can you give us your genetic information forever? And that raises all sorts of problems. So one sort of classic ethical issue ever since the creation of biobanks, or at least once we understood what it meant to share genetic information long term, is how much do people really need to understand about this process? So sort of learning health systems position that people have taken is you don't need to know that much because this is low risk, and there's some sort of mutual expectation that by contributing to this low risk research, you're going to benefit. And so really this is not something that we really need to make sure you understand. It's one sort of thought you might have. And then sort of a second follow-up question is, so what should we do, though, if we know that people don't understand? So it's now become, I think, well known that people don't understand consent in lots of different contexts, especially in biobanks. But is it a problem, then, that if we know that we have some evidence to think that people don't understand the basics? So do they even understand that they're donating to a biobank and that's different from a blood bank, or that this is going to be used for research, not their own care? Some of the basic questions. And these questions have become more and more important because now we have options for addressing comprehension issues. So people have talked about the NIH's All of Us program in the last couple of days. They've been pushing this idea for the last few years that we should make consent actually harder for patients. So in a way, we're going to make it fun and engaging, but part of that idea is we're going to provide friction so that they have to engage with the material. They don't realize that they're actually learning from the consent form because we make fun videos or illustrations, but then we pop in quiz questions and little opportunities for educating them about key bits of information. So even though this is potentially resource intensive, there are options out there. There's software, interactive portals to make sure that people understand something. But a lot of health systems, including IU Health, are wondering whether it's still worth it. So is patient understanding or participant understanding so important that we do need to provide this friction, we do need to invest in the resources to make sure people understand? And we do know, even in very specific biobank contexts, that misunderstanding is going to happen. So a group here did a review recently where they found that across all different biobank knowledge tests, an 80% sort of comprehension threshold is rare. It's rare to see anyone, no matter how many questions there are, get above an 80%. And those are usually in ideal conditions. So if you make it more realistic and actually assess people at the time of their consenting, at the time of going to the clinic for something else, comprehension is way lower. So Sarah Garrett's team did a study where they first tested their normal consent, and average comprehension was about 58%. They then changed their consent form, made it better, still only 64% comprehension, which seems kind of bad, enough that you might be concerned. Like, people are failing comprehension tests, even on things you might think they should understand. And then recently, Laura Beskow reported the results of years of research trying to get the perfect sort of consent form for biobanks, where panels of experts had helped her create, just the exact wording you'd need for people to understand the most important information, which led her team to think, or to argue, people should get 100% right on this test, but they still only got 83%, and on some specific, very important questions, like related to privacy, people were getting less than half of the time. So with that as background, biobank consent forms are apparently hard to understand. My project as a postdoc at IU has been trying to assess our integrated consent process. So IU Health, just a quick background, is statewide. So we had this goal a year ago. We're going to start integrating the biobank consent into all these different locations. We're not there yet, but we have it at a lot of locations. And the process at the moment is that we approach people at the phlebotomy lab when they go there for other tests. So it's not in the clinic exactly. Sometimes we do that depending on the clinic. But at the moment, we approach people when they're getting other blood tests and ask if we can have an additional vial of blood. We connect it to their EHR, We get their consent for that. And then we say it'll be de-identified when we share it outside of the Indiana Biobank. We also went through a process of simplifying the consent form because we thought, okay, this is a totally new process. We have to make this easier to understand. So we did sort of the common rule thing of we had a concise cover page with bulleted statements of the most essential things. We also created this illustration and tested it with patients to make sure they understood the basics, they were satisfied with it. And we put it on a tablet, so it's currently in an electronic format. It's everything about this process, in short, is designed to be very easy for the patients, as easy as we can get it. Got the consent form down to a 9th grade reading level, which isn't great, but when I started my project, I would say I expected to hit around 60, 70, 80% comprehension. So the rest of this presentation is me telling you bad news about my project. So what we did to assess the comprehension of our patients, we took some questions from that Best Scout study I just mentioned a little bit ago, where she had really well-formulated questions. We got it down to just 11 questions about the things we thought were the most important. And then we hit people with a survey, including those questions as well as some satisfaction questions. And even though we weren't getting the survey done, right when they consented, we got them within a week for the most part. And here's what we found. So 53% correct on average score of the 11 questions, so that's about 6 out of 11 correct. Not as high as we expected. And you'll notice, sorry, you can't see the questions, the full questions. I can tell you what the full questions were. But you can see the topics that we were trying to assess, and you can see that 3 of them were extremely low. And these were the ones we were very concerned about. So one thing people really didn't seem to get was that we're accessing their medical records and that access will stay long-term. It's not just a one-time collection. They didn't understand that we were sharing data outside the biobank for any purpose. And sorry, I should have said, these are all true-false questions, so some of them were reversed. And then the last one was that they didn't understand that there was an in-principle risk that their info could be accessed. So we asked ourselves when we got this data back, is this problematic? We were expecting higher numbers. How bothered are we by these numbers? And we said, okay, we're pretty bothered. We have to do something, we think, because it is a new process. Is it that they're not fully informed? Are they forgetting? What's going on? So we did 2 things. The first thing we did is we were trying to figure out, okay, we have this great illustration that I showed you. People said they liked it. They seemed to understand it. We also have this great cover letter, cover page. What if we put basically the same information right above the signature line? So 6 bullet-pointed statements right above the signature line where they say, yes, I want to do this. Maybe that will improve their comprehension. We're essentially teaching to the test, thinking, surely this will do something. And then there was one question that we thought was sort of vague. We asked people whether they understood that we were putting information into a database outside the biobank, which we didn't think was quite accurate, so we changed that to shared outside the biobank, hoping to get that one question to go up. Again, hit people with a mix of email, phone, and mail, got to them as quickly as possible. And although there's some variation, none of these differences are significant. So we did not improve or we didn't change the questions in any way, which I was totally surprised by, especially on the ones where we hit them both with the new question and the new bullet point statements. We expected more. And so there's the average scores shown there. Comprehension didn't improve. I should say I don't have data up here. Satisfaction remained high. We had a question, do you feel like you have enough information? They all said they had enough information. as far as we could tell, there was no problem otherwise with the consent process. So some of you may have seen a sort of follow-up to Beskow's work that I mentioned earlier, a paper that came out last spring, where Laura Beskow presented her own knowledge results to the panel of experts who had helped her create her questions and her consent form, and asked, hey, what do you think we should do? Sort of the same question I'm now asking myself and my group. What do you think we should do now that we know people are misunderstanding quite a lot? And to her surprise, her panel of biobank experts, some of them may be in this room, I don't know, half of them said, I don't think it's a problem. Even though I previously said this information is essential, I actually think it's fine now to allow them to enroll, even though we know they don't understand some of that information. So on certain items, they would say, we at least need to re-educate them or provide some education to them to make sure they understand this. Otherwise, they didn't seem to mind. And so that's sort of where we are as well right now. So we're still facing the problem of why aren't people understanding? And what sort of obligations does that put on us to improve their comprehension? So I'll lay out a few options. So the first one I mentioned at the beginning, which I think of as sort of, this might be unfair, but a learning health systems advocate's response is something like, I still don't see why this matters. It's low-risk research. You might argue informed consent isn't even that important. We should just disclose the information. It's there for them to read and study if they want. Even if we are going to get their consent, why should we really be bothered by low comprehension? A second idea, which is I think is where we are now, is we should try something else. So especially for questions like they don't understand that we're accessing their EHRs, we've got to try something. So there are things people are pursuing where you put information in patient portals to remind them again of what they've signed up for. They're, of course, given a copy of the consent form, but maybe they forget some of the key bits. Maybe we could incorporate something like the all of us consent, where we remind them multiple times of what they've signed up for. But we should do something to at least make sure they understand that they're signing up for research, that they've shared their genetic information long-term, things like that. And then lastly, we're also doing some follow-up surveys and studies right now. Ask patients what they think. So if you confront patients with the information that, hey, you don't seem to understand the thing that you signed up for, what do they recommend? And sort of, this is not like a definitive conclusion, but what we sort of are finding is that people aren't concerned, the patients aren't very concerned either. So they'll say things like, well, I just wanted to help in any way I could, and I trust you all, I trust the system. I don't care if I didn't understand X, Y, Z. And generally, they have other things on their mind when they go into the clinic. They don't want somebody pestering them to make sure that they have perfect knowledge of what they've signed up for. I'm not going to advocate for any one of these as the right view, but I think this is where we are at the moment, and I'd be happy to hear your ideas about that. Thanks.
All right. So good afternoon, everyone. So I'm excited today to share with you a community university partnership and project that's focused on addressing the opioid crisis. So this was funded through the Michigan Institute for Clinical and Health Research.
Sorry, do you mind stepping a little closer to the mic?
Sorry.
Thank you.
All right. Is that better? Yeah. All right. So just to give you a little bit of background about this project and sort of what how this was launched is really aimed at enhancing real-time access to data, information, interventions, as well as to advocate for institutional responsiveness to what we now call the opioid crisis, particularly in Detroit as well as Wayne County. And so, I say what we now call an opioid crisis because, as I mentioned in my classes, Black and brown folks have been dying from opioids for decades, particularly heroin. And so, as my recent visit to the NIH and hearing one of the directors stand up in front and say, make no mistake, the reason why we now have the resources and the research is because it's now affecting communities that look like me. So there's a white man standing at the front. So it was empowering to hear that recognition, that acknowledgement. And in terms of some of the main components of our project, it includes a learning community. And so essentially what this learning community consists of, or some of the mechanisms through which we hope to create some change, is it essentially works like a think tank, right? So we're there to gather information, different perspectives, share resources, engage community members, different stakeholders, and employ principles of community-based participatory research where we involve the community, the target community, in all aspects of this project. So everything from identifying what the problems are, what the issues are, to what are the potential solutions and what we can do to address some of these challenges. Taking that information, the next main component is, on the policy brief. And so essentially, again, all of this is driven by the information that's gathered through, for example, community members' testimonials, as well as data that perhaps they may not have access to otherwise. And then the third aspect of this is the community engagement. That has been somewhat challenging, and so of course this project started off in 2015, and we have started with a set of community engagement and community partnerships, but to date we haven't had any new partnerships. And so this project really takes a team science approach in terms of just having folks from different disciplines across campus, everything from social work to nursing to medicine, really aimed at, again, taking that team science approach, gathering different perspectives in terms of how we think about some of the driving mechanisms of substance use and behaviors and substance use disorders. But perhaps more importantly is the community aspect of this, right, and engaging communities. And so historically, that hasn't really been taking place within a research context. And so from this perspective, interventions will only be as effective or efficacious to the extent that communities are willing to uptake them. So the goal here, again, is to involve community in all aspects of this process. And so again, in terms of how this partnership started is back in 2015, and so along the way, we've engaged additional partners with various levels of expertise in different areas. So just as an example of that, I joined this team last year, and my research area focuses in adolescent substance use preventive interventions. I think by the time, unfortunately, I think we, live in a society where we're really focused on intervention, and I come more from a prevention aspect where, prevention starts from infancy early on in terms of how we can really make change and reduce some of these risk behaviors that youth are engaging in. And so by involving community members, again, we're able to identify some of the key areas that folks wanted to address or felt that the community should be addressing, including substance use preventive interventions, mental health awareness, access to mental health services, and enhancing interventions. And so we had, like a retreat to gather some of this information, focus on opioid, and it has evolved over time. So initially, the goal was to focus solely on opioid use and dependence. This has evolved to include different aspects, including adolescent substance use, as well as the need to gather additional information focused on marijuana, as well as recovery. So again, through this community university approach, we're able to identify key areas that we should be focused on collectively, rather than us standing in the ivory tower and dictating sort of what it is that the community needs. So Karen will be talking about some of the key findings of that policy brief.
Thank you. So as David mentioned, our series, it included 5 sessions, and these are the topics that were presented. Each session included a panel of 2 academic and 1 community partner, so the sessions were opioid use among adolescents and young adults, prescribing marijuana, and we had 2 sessions on recovery. And the session format included a panel discussion followed by deliberation with the group on any questions and answers and comments and things they wanted to key in on. And we allowed participants to share, testimony. Especially those who have been particularly impacted by the crisis, either those dealing with recovery and addiction, or supporters or peers or family. And so that sharing was all documented, in our notes basically, and recorded. I slid a slide in on you, David, as a presenter of the youth data session. And so I wanted you to get a feel of the breadth and the diversity that we shared. David, his expertise is in youth, and he's doing some great work with involving youth in decision-making on the research that he conducts. Darlene is with our county mental health authority. And so she shared on, and she's over substance use disorders there, the programming. So she shared the resources and opportunity. That county organization in particular, I just went through a reorganization, so it was really timely to be able to share, the structure changes. And then Terry is out of the School of Nursing and has a center there where she co-leads on the study of drugs, alcohol, smoking, and health. So David shared on youth data, Darlene on programs and resources, and Terry kind of honed in on the impact that sports and how young people are really getting addicted as a gateway, that opioids is a gateway really from injuries. And the advocacy for more non-traditional methods such as pain centers and yoga and those types of activities to educate parents and young people on, that those are good alternatives. All of that was massaged into, that information was transcribed from each of the 5 sessions. We lumped it all together and kind of worked it to where some priorities came out. And so this is our October policy meeting where we had about 45 to 50 people attend. We've always stayed together as a full team for the presentation and the deliberation, and that worked well for us. So at that meeting, we landed on some priorities for drafting. It was actually to draft the policy brief. The expected outcomes of the brief are consensus on issues to frame for research, to encourage a timely response, to advocate for policy action and a call to action to facilitate that. And then really important is the community-based dissemination of research. So the themes from the qualitative analysis that came out at that meeting are culture, stigma, family cohesion, access to data, and access to care. And our group really played with how to merge some of the categories. For example, they really felt that family cohesion probably could be lumped under culture and stigma. Here's an example of some of the comments that our partners shared in terms of for the access. I'm sorry. So those 5 themes were at the policy meeting narrowed down to 3. The first one is access to care, interventions, and resources. And so, here's an example of some of the comments from the various 5 sessions that, were recommended or used to, for this sub-theme. Dollars aimed at treatment, put dollars from cannabis sale into prevention, like cigarette, alcohol, taxes, include people in recovery who represent and are experiencing recovery and decision-making on access to services. For family and community support, so this is the sub-theme that they felt could probably be lumped under access to care, interventions, and resources. Grandparents becoming parents because children pass, difficulty taking care of children, kids experiencing trauma from loss of parents, interconnection with care cycles, education on the impact on children, what's going on with use and access in neighborhoods, and finally access to data to encourage CBOs, others access data information and increase visibility of the good work occurring. Sharing behavioral health data is difficult, constraining coordination of care among providers. Smaller providers are even more challenged with accessing that data. Those 3 themes were collapsed into one yesterday at our policy brief meeting that we had as a workshop here. And that created our second draft of the brief, and we decided to focus on stigma. We had about 6 partners, and before I go back, I should recognize that Tina is here today, and she participated in the October meeting and is opening Substance Use Disorder Center at the end of this month in Detroit. So at yesterday's meeting, we collapsed everything under the issue of stigma and identified, because stigma was discussed very thoroughly in all of the 5 sessions by our participants who attended those sessions. So, the problem is the fragmented system of access, the lack of access that community organizations have to data on substance use disorders, the whole coordination where there's no real-time process. So our objective is to advocate also in terms of problems, stigma itself, and how diverse and how broad the reach of stigma impacts everything. There's the face of addiction, as David mentioned, is very different. And stigma goes across everything. So we felt that, in terms of what we could impact, that probably would be an opportunity, especially if you look at some earlier movements like the HIV and AIDS, efforts that really were able to embrace and change, stigma against that population. So our objective is to, address stigma, to really kind of create a call to action that, for addressing stigma and to change, and infuse non-stigmatizing practices and behavior in the SUD, substance use disorder practice. And so our audience would be community organizations who are on the ground floor, really working with this population, but also those who they collaborate with, for example, healthcare providers, law enforcement, other large systems, funders who support them, all towards a movement to create a priority on stigma as a core philosophy on, a better way of treating people with respect and dignity. Our other audience would be the University of Michigan, since we're here, that we begin to advocate, at the university with, for example, with our institute at MISHAR, who's a CTSA, a Clinical Translational Science Award, Poverty Solutions. As David shared, our leadership team, we have social work, School of Public Health, nursing, pharmacy represented on our team here. So to begin to share what our partners are recommending, and that they consider using that information to guide developing, a focus on stigma. And then finally, our recommendations, again, as I've already shared, our advocacy, the language and messaging and imaging of how to care and treat people. We'll develop our dissemination plan is focused on a communications plan that would disseminate this information in community and academic venues, advocacy, and that a big part of that would be working with other partners. For example, Michigan Open, who is addressing the opioid crisis, is on our team along with the Injury Center, so working with their folks who are doing advocacy, and then partnership development, as David mentioned. That was one of our weaker areas of actually developing new partnerships in the community. So we hope that this forum building kind of opportunity will enable, new partnership, community academic partnerships. And so our next steps are to finalize the policy brief, to implement a dissemination plan for it, to replicate the Learning Community Series again, and then we have no money, so grant seeking to do all of this. Wayne State University is replicating this model through their Center for Behavioral Health and Justice, and I just wanted to mention that some of the metrics from just doing the series itself, we found quite interesting. For example, we started with a mailing list of about 50, ended up with like 300 stakeholders or so who participated across all of our events. So word of mouth was a really key thing. We had an infusion of Wayne State University, especially the physicians group who were attending our sessions, listening, hearing. Of all of our partners, CBOs were predominantly the audience. The university community engagement with the university going into the city of Detroit, presenting their research, getting feedback on it from our community partners telling them what our issues and problems are, and they are considering those areas of new study. And we consider all of this formative, especially as we move forward on replicating the series, or maybe building some type of a coalition environment for deliberation and, advocacy right now around stigma, but we do recognize how mental health crosses everything, all boundaries. So with that, thank you.
Thank you, everyone, for those great talks this afternoon. We are going to invite the audience to ask questions, and there will be microphones floating. Gracie's looking for there it is. I will ask some questions while we gather interest from the audience. What struck me across this panel, a really important panel that, again, centered patients and communities, were notions of trust across each of your talks. Andrew, I was particularly struck by your comment that you said, they trusted the Block M more than they trusted their physicians. But I'm really interested in hearing about the perspectives that came, if any came, from those that don't trust the Block M, that not only do I not trust my physician because of certain reasons, but I certainly have some issue with the institution itself. For TJ, I'd like to hear more about the kind of engagement that was taking place as you went through phase 2. in terms of how you engage with the individuals. What struck me was that you said they don't care. And again, I want to push back and say, what about those that do care? And then Karen and David, I was particularly interested around the stigma piece. And you said stigma ELSI workshop. So I wanted to know what specifically did you cover that was around the ethical, legal, social implications of stigma? Because stigma is so multidimensional, and there are so many things that can come from a conversation like that. So how was this focused around ELSI conversations? So we'll start there while we get questions from the other parts of the audience.
So, Professor Curry, that's a great question, and one that's easy to answer, but with a very unsatisfying answer, which is that we had a biased sample of people who had already signed up to participate in this research, and the vast majority of them were drinking the same Kool-Aid we were. So I think it's really more of a limitation of our work rather than something we can speak to at length. We do know that in precision oncology research, generally speaking, we're dealing with populations that are more trusting than the general population, and certainly than those who have not enrolled, who were eligible to do so. I think Vince Bonham and Shaniqua Collier's work is apropos here in that we need to do better at diversifying our samples, both across race, socioeconomic status, perspective, and everything else. But the sample that we were analyzing were people, generally speaking, who did trust us and did trust our system. It's a challenge and an opportunity for us to reach out to those who don't.
So I think the question was, what about people who do care about lack of understanding? So far the people I've talked to who care, they end up making recommendations like, what you need to do is better bullet points. or things that we feel like we've already done. And so I feel like the trying new things is where I am, because more information in the consent form I don't think would necessarily help, but some people do clearly want a better presentation of the material. We just have to figure out what that is, if it's better wording or like an interactive portal of some sort.
Because when you talk about it post, right, my data's been disseminated towards particularly commercial industries, there's a whole lot of people who are then taking a lot of point to care.
Yeah, and we have not asked anyone about commercial agreements. So when we say data sharing outside the biobank, we don't say what that is. And are you bothered by this type, or this type? That's something we need to ask. So.
And David, since I was there yesterday, the ethical would be that our partners report that people feel dehumanized by, even the care-seeking process, by the way that they're treating. The legal aspects would be that those folks are licensed for care. They're not really, the way that they're doing it does not encourage care. It detracts from the care-seeking process. And then the social side is that, that the crisis impacts so many people. It's not only the person who's dealing with addiction or recovery, but also their family, the children, their peers, and so they also feel stigmatized and feel stigma from, having a family person who's dealing with this. So we just want to make these issues more, increase awareness, and that and change the way that folks are treated and perceived.
Hi. So my question is for Dr. Kasper-Bauer, and I was wondering if you could respond more specifically to the point that Dr. Schumann made during his presentation of when we're talking about precision medicine in oncology specifically, that the risks to the patients of the surgeries that they're about to undergo are so much more profound than potential dignitary harms derived from data sharing later. And I was wondering, so you talk about sort of really trying to emphasize in the informed consent form this sort of rectifying this data usage misunderstanding, but is that worth being the one thing in the research informed consent form that we really emphasize? By doing that, we also de-emphasize everything else in the informed consent form. Is that really the most risky part of the informed consent?
Yeah. So I don't think it's the most risky. It does seem to be the thing people are confused about the most. So when we've done some focus groups, people have said, okay, I understand you're de-identifying my information, but then, and you're going to, be confidential with it, but you're also saying there's this risk. Those are two conflicting ideas. And so we have a lot of information in the consent form trying to explain that, and it's hard for everyone. Even other researchers aren't quite sure what we're saying there. So you're right. So what then ends up happening is people say, oh, there's something here. This is the important stuff that I should be focusing on, not everything else. When I think I would agree with you, it's not probably the most important. But I'm also concerned that long-term we don't know how people's samples are going to be used. So I do want them to understand that there is this long-term, in-principle risk that it's not like we're just using your sample today or this year and then it's going to be gone.
My question is for Dr. Schumann, and it's about the first part of the research results you gave us about just general enthusiasm for research. And my intuition is that cancer research in America has a certain kind of cachet and exaltation that other forms of medical research don't. And that, and even that trust in the block M, I get the feeling that the cure for cancer, there's nobility in that people don't see in other kinds of biomedical research. And so I guess my question for you is, one, do you agree? And two, how can we, and it seems like, as someone who doesn't do cancer research, that makes me kind of jealous, right? I'd like to see my patients have that same faith in the research enterprise. So I wonder what you think we can take from your experiences with research participants and broaden them to a wider range of people.
So empirically, that's true. So the best data on that, so some of it actually came out of Michigan. Sorry. So empirically, that's true. So there are data out of here, actually out of folks in this room who have published specific to cancer patients and their willingness to enroll. There's also a beautiful paper by Deborah Matthews in The Oncologist last month that covers this as well. So empirically, that is absolutely accurate. The harder question is, why is that a matter of us taking advantage of vulnerable cancer patients, or is that us being more enlightened in oncology and we need to be able to do so in other fields as well? I think the answer is probably both in different ways. There is something, again, speaking now not as a ethicist or a researcher, but as a cancer doctor, there is something about the desperation of someone facing a life-threatening cancer that I think is fundamentally different than other aspects of medical care, in the sense that there is not an emergency, but there is this sense of mortality and fatalism that, for whatever reason, begets interest in being a part of something bigger than their own disease.
Yes, my question is for Karen and David in reference to the stigma and also the historicity of opioid addiction. I have the opportunity to be bi-coastal, and so I do a lot of work in Malibu as well as in Detroit. But the same thing comes to grip with everybody's family. 1 out of 26 people are addressed with the impact of family trauma because of one person that is addicted. So moving the person from shame to healthy shame seems to be the issue when it comes to our social stigmas and labeling. So what do we do to bring awareness? Because when you expose it, it brings healing, and so many people are ashamed, whether it's in the hills of Malibu to the city of Detroit on Mack and Bewick. I would like to know, what can we do to collaborate an effort to help people expose it before we see it on Channel 2 or Channel 7? Can you help me with that? Because that's what I'm dealing with. And whether or not they pay $50,000 for treatment a month or have Medicaid, it's still an issue. Can you help me with that?
I can start and share with a story that one of our partners, Linda Davis, was here yesterday, and she's a former judge out of Macomb County and over families against narcotics, a judge of a drug court. She shared a story that she had a project with the media, and they had identified a person in recovery, and the media worked with them. Well, when the media presented the story, they had needles and all this really very ugly portrayal of this woman in recovery, and she shared that they didn't realize themselves that they stigmatized. So even our care providers who are addressing, substance use disorders, can stigmatize families and individuals. So it's really about, increasing the awareness of our practice, and increasing a sensitivity almost. It's not a sensitivity that we have for cultures and differences. We have to have that for people with diseases, because people with diseases are stigmatized as well. So that's a start anyway.
Another program that I'd point you to specific to that was presented at ASBH this past year by a group at Temple's Urban Bioethics Center, looking at a community outreach for the exact issues that you're dealing with. And the specific component that was most important was engaging members of the community, many of whom were recovering patients themselves, to be a part of the intervention in the community. So that work by Nicole Strand was really a nice illustration of exactly what you're talking about.
And I'll just say we kind of brainstormed doing a toolkit, and the policy brief will focus on stigma, but it'll have a cover that shares all the other important information we glean from the series, and the advocacy plan will, try to be in the right place at the right time when decision making is occurring, and try to impact decision makers who have basically funding, and policy responsibilities to be more aware of their approaches and encourage addressing stigma.
So, if it's not on, okay. Yeah, so as was mentioned earlier, stigma is at multiple levels, from individual to structural and societal. That if I had a magic wand, I think, in an effort to reduce stigma, it would really be to stop calling substance use as the problem, and rather looking at it more as a symptom, right, of various aspects of society, such as poverty and inequality, as well as other, co-occurring issues such as mental health. And so thinking about sort of what are really the driving mechanisms of substance use.
So I have a question for Drs. Schumann and Kasperbauer. Why is the gold standard for informed consent 100% understanding for patients? Why isn't it something less than that? And just by way of comparison, I was thinking about this a little bit. There are many complex behaviors that I think we routinely undertake that require something similar, for which I think it is fair to say we do not actually have 100% understanding of what's going on. I do not 100% understand my health insurance policy, and I'm a health policy researcher. I don't understand my home insurance policy to 100%. I don't understand my mortgage to 100%, but we don't ban people from buying homes. And so is a better way of thinking about this that rather than the standard being 100% because we're worried that someone's going to be left out of the dust, that there's actually some surrogate endpoints for what we think the appropriate level of understanding for informed consent is, and then afterwards we should just stop, right? I'm just curious.
So the 100% from Beskow I thought was funny, because I didn't think people would agree with that idea. I think it was more like, we've done so much research to make this good. How could you not miss these questions, or how could you miss these questions? And yeah, I agree. So in her research, she's basically winnowed it down to okay, what's the most essential? Could we say there's one essential thing you should know? You should know you're involved in research and we're taking your blood. That makes sense to me. But then the tricky part is when you're like, we've presented it so well, though, and people say they care about it. They say they read the consent form. It seems like we have to do something else then to meet a higher standard. Or are we just being, lazy?
So I listened to iTunes and signed the release, and I'm very happily ignorant of what was actually in that release while I'm listening. So I completely agree with you, and I do not think 100% or even a certain numeric threshold is necessarily how we define appropriateness here. I think one of the challenges is what is easy to regulate is what is written on the piece of paper and whether it's signed and dated appropriately, much more so than how people feel thereafter. And I think from Professor Kasperbauer's work, what's striking is that all of these people were happily ignorant in the sense that they did horrifically on your survey, but they were satisfied. And I think that in and of itself is something that's worth kind of reflecting upon. What I worry about is that the most vulnerable are probably going to do the worst on that survey. And I don't think we should be fatalistic and accept a complete dearth of effort to inform based upon they're never going to get it anyway. And I think that's going to create more problems for the most vulnerable down the road. But I completely agree with you that high thresholds of comprehension and retention are the wrong answer.
If I could ask a sort of a follow-up question. What I think your data suggests is that people currently trust healthcare organizations in this regard. Well, maybe the more apt question may be whether our practices are themselves trustworthy. And I think there might be reasons for pursuing this higher level of disclosure and assuring that people actually understand that, because we're anticipating questions that they may have in the future, and some of those questions may actually compromise the historic trust that people have given us. And so maybe the question isn't how much they understand, but how much we hope that they will understand and sort of willing to accept in terms of trust later on. So yeah, just a counterpoint.
I think that's especially relevant to the commercialization question from before. I suspect anyway, there's some research on this. People trust institutions who they give their genetic information to or other biological tissues and don't realize that they are commercializing. And they say, yeah, if I found out that you were commercializing, I would trust you less. So that is a risk for us.
Thank you. All right, I'll close us out with the last question or a thought. So I was thinking about the concept of futurity and potentiality amongst all of your talks, and I wonder if you could all speak to the ideas of aspiration and hope and futurity and how that plays out in each of your talks and maybe the broader sense of your work. I think that this idea of being involved in something for a greater good, whether that greater good is within myself or society, propels medical advancement, and it propels all of these ethical questions we have because it's situated in the fraughtness of society. And so if you could speak to how the idea of what this can do for future lives, either their own or some sort of imagined potential, that would be great to close out on. Thank you.
I'll start with, we've got to do a better job with disseminating our work in the community. We hold it here, and we only are disseminating it broadly in academic venues. We've got to get it into the community with the people who are on the ground floor serving populations and vulnerable populations. They're working in, the disparity is huge. They're working in a vacuum. And so, it's a very receptive environment when we do it, and so we need the community to access the research and the data so they can, they can translate it. They're brilliant at translating, that information into practice. And so that's our responsibility both here at the university on the community side to improve practice. And one thing also that we found that many of the community organizations were using the series as a training mechanism for their staff. We had many who would send 4 to 5 staff to be, to these sessions so that they could, hear it and learn it. And so that also shares the gap, that community partners and organizations are having, and I mean these are large organizations, are having with being able to access this information.
Yeah, so in terms of hope, just kind of following, Karen's comments about dissemination, for me in terms of impact, one of the most rewarding aspects for me of community university research is by involving some of the community stakeholders in, for example, publications. And so in my most recent, 4 or 5 publications have had youth advisory board as co-authors, the clinicians who are in the community-based organizations who are delivering services, and other stakeholders. And so for me, it's just a way of opening up doors of opportunity, particularly to vulnerable populations who have not historically and presently have had access to universities such as Michigan.
For me, I'll just mention more talking to patients. They seem to have low expectations on getting anything back, and although there's a push for returning results, and that can go wrong, we can return results too fast. I hope, I guess, that the IU Biobank and other biobanks can turn these massive collections of biospecimens into something for patients where they don't seem so dismissive when I ask, like, what are you expecting to come from this?
And again, to reiterate the points in terms of oncology specifically, I think the vast majority of patients participate in this not only for their own benefit, even if that is their primary motivator, but also for the altruistic sense that we are doing something for future patients and for the legacy of cancer care for our children. I think one of the main lessons there as well is that we cannot be so protective of our own dignitary harms, whether it's based upon retention of the informed consent document or how we define a human subject regarding the common rule revisions, that we are hampering research simply to protect people. And I think there is this tension between protection of subjects and generalization of knowledge and availing specimens and data for all of us to use in learning health systems or other types of research that is a critical driver of the future of medicine. And we will protect subjects to some sense only in a way that allows us to continue to facilitate the research that we all agree needs to be done. And the challenge for all of us is to mitigate that tension down the road.
Thank you. All right, so we have a few minutes before we are slated to close this discussion at 2:30. Should we take maybe a 5-minute break or should we go straight in? Okay, so thank you to all of our panelists and to our audience for such an important discussion. That was our last panel for the symposium, but to give some concluding remarks and thoughts on next steps, I'd like to invite Dr. Platt and Professor Spector back to the stage to close us out. And again, thank you for this important panel. Thank you.